medicine in general is this ability to connect with people. And you kind of are constantly expanding your own horizons by being invited into other people's lives. What digital health now means is not everything happens in the big hospital in the city. That's not where healthcare happens. Healthcare happens with you wherever you are. So if you're in your home and you're in your town, that's where it should happen. So there's something about health questions and an inability to get a quick answer that makes people very willing to trust it. And the science is good, but it's not perfect. It is 70% right, but 30% not just wrong, the opposite of useful, dangerous. You can't trust these systems. It's not consumerism, it's patient agency. People wanting to know about their own bodies, people wanting to know about their own health. That's great.
In this episode, we will explore how technology is reshaping the future of healthcare, from telemedicine to artificial intelligence and wearable devices, and how innovation can expand access to care worldwide, particularly for populations that remain in disadvantage. To discuss these topics, I have the immense privilege and honor of welcoming Dr. Ami Bhatt. Dr. Ami is an American cardiologist, Chief Innovation Officer of the American College of Cardiology, and the inaugural Chair of Digital Health Advisory Committee of the FDA. Welcome, Dr. Ami, for accepting my invitation to be part of this podcast.
Thank you so much for having me. This is lovely.
So I wanted to start with the beginning. What motivated you to become a clinician? And what are your earliest memories that shaped your career path?
You know, we get asked this question a lot. I think, those who are out there who've been in medical school know. And I definitely liked science and I liked people. And that's kind of one of the more common answers. I think what I really like about medicine in general is this ability to connect with people very quickly. Right? So all day you get the chance to just meet new people and new environments, and you kind of are constantly expanding your own horizons by being invited into other people's lives. And I only know that now. I don't know that I knew that in the very beginning of my career, but maybe I saw it. A lot of my original doctors worked out of their home. And so it was really one of those environments where I saw how they cared for us as patients and how we became their extended family. And I think that's a lot of what attracted me to the clinical side of medicine. And then, of course, I really do, I loved science. I loved the body. I loved kind of the investigative nature of medicine. What's going on? How is this happening? And so I think a lot of those things kind of came together to make me want to practice medicine. But I do know that when I first started, I wanted to do both medicine and pediatrics. I wanted to make sure that I was trained so that whether you were 0 or you were 100, I knew how to take care of you. And so definitely that kind of caregiving and being able to help anybody that walks in my door was a huge part of that for me.
So you trained at Harvard and Yale University, very prestigious universities, to become a successful cardiologist. And now you are a global leader in innovation in the healthcare system. So how much of who you are today was shaped by the systems that you train in? How much by the gaps that you saw in them?
Yeah, it's a great question. I think, so I definitely loved where I studied. I think most people will say that though, right? I definitely loved where I studied. And there's no doubt that the people around me, whether it's the institution or not, the people around me most certainly shaped kind of who I became, my mentors, my peers, many of whom are still in the same circles as me today, which is great, seeing people who I knew from college or from med school. But later in life, maybe not the college and med school and training part, but I think the practice part of medicine was where I started to see some of the gaps. That, wow, I know we've always done it this way, but it seems not ideal. Why is it so hard to do something better? And so I think the training shaped me to be who I am, but I think it was then the practice environment that made me start to think, I think we can do this better. But there's a lot of inertia to changing the way in which we do things. And I think that's kind of what drove me to thinking about innovation, right? And just care delivery and systems. And not how do we just advance science, but how do we redesign how we're delivering care to people?
Great. So you were trained as a female clinician. And how was your journey in terms of being a female clinician, and how that shaped who you are now?
Yeah, it was the best thing ever. I was just talking to somebody earlier today. But my patients were my friends. And especially when I first started practicing, I would take 30, 45 minutes, sometimes an hour with someone if it was a really, tough
Hmm.
decision we had to make or they were having a tough time. And yes, I was often late for my patients, but they were always willing to wait because I was always willing to give them the time. Uh, and, and I think that really shaped who I am. My patients shaped who I am, and those interactions did. I do think the healthcare field has changed because we've had fewer and fewer clinicians available to take
Hmm.
care of more and more patients. And that's true globally, but definitely in the US where I practice. And so we got to a point where you just had to move faster. You had to see patients faster. You only had 15 to 20 minutes with a patient. And that I think is very different than the way many of us started wanting to practice in medicine
Hmm.
to really spend that time holding someone's hand, explaining, spending quality time. And now we find that that's why a lot of these advances that we'll get to, talking about AI and data and other
Hmm.
things, the goal is to get rid of all of the administrative work and everything else we need to do so we can, in fact, dedicate the time to spending with patients. But I definitely think that being a clinician and really my patients, my interaction with them, it kind of shaped overarchingly who I am today.
So at what point do you realize that improving healthcare might require transforming the system? And not just, you were mentioning about treating the patients and the difference. One thing is spending an hour with the patient where you can do a more thorough examination or evaluation of the patient. And another thing is doing it in 10, 15 minutes, which is big proportion of that is just admin work.
That's right.
So,
That's right. Yeah. You know, I actually think it was back in the mid 2010s when my patients really said, "Why do I come in to see you to talk about my most recent tests?" Very valid question.
mhm,
Why do I come in to see you when I've already had the testing? What is the purpose of sitting together in the office when my CAT scan or MRI or ultrasound is already done? Is there something truly additional that I am offering with my vision and my holding their hand and my stethoscope every single time? Now, if you have congenital heart disease like my patients did, you get a lot of imaging and you got a lot of studies. And so it was frequently that there were things that we were doing for them. And I thought that was a great question. And I said,
mhm,
actually, you know what? If it's just a conversation, if my exam is not going to change your management and your outcome today, it doesn't mean I never need to examine you, but maybe it does mean that for today, I should just talk to you about this, right? And I like to see my patients. The phone is fine. I really like to see because there's something about facial expression, how people are talking
mhm,
to you, how they're interact, right? That's really important in human communication. And so that was the first time I realized when I started telemedicine in around 2013 that I had realized, hey, there's a way to kind of do this better. It was around the same time that I also took a design thinking class, maybe late teens. I took a design thinking class at the Harvard Business School. It was taught by Dr. Shrikant Thattar, who's actually now the dean. And it was the first time I'd heard of a design thinking class. And I said, "Oh, like how does this work?" And I remember I audited it because I was practicing at the time, so I couldn't, do a full course load. And I learned so much by other businesses and
mhm,
by non-healthcare and by thinking about when something was ineffective, how do you then make it better? And I learned a lot about change and leading people through change because it's not just the system, it's the people in the system.
of
And so I
course,
think
yeah.
that all happened in the mid 2000s. And that was my first taste of not only, hey, we're not doing things optimally sometimes, but also we're not doing them in a patient centric way. And there's an entire theory of design thinking that can help us reorganize this.
Yeah, you were mentioning about that you had to see the patient. It's basically like, it's like a FBI detective that is sort of getting those clues from the
Hmm.
patient. They're saying fine, but you're seeing that they're not fine, etc. So
Yeah,
it's
yep. That's exactly right. That's exactly right.
so how innovation has and will continue to improve healthcare.
I think we say the word innovation, but we mean a lot of different things.
Yes.
I teach a class at Mass General, or started to teach, and now they've moved on with it, but called the MJ Elevate program.
Hmm.
And this is a leadership program for chief level people, right? So people who are
Okay.
really in charge. And the idea behind it is we're not just going to take people through change and then things are stable, and through change and then things are stable. Now with technology, digital health, AI, data, things are consistently changing all the time. There's never a day where we say, "Oh, this is the best ChatGPT. It's not getting any better."
Yeah.
Every couple of weeks, it's getting better. And so when you think about healthcare and you know that things are consistently getting better, how do you, with innovation, assess I'm doing well right now? I don't need to take this new technology. Or here's the area where I have an unmet need or a gap. And for that, I need this kind of technology. And now that technology is here and I will implement it. Or, hey, this area is a real mess and I don't see the technology for it, but I think maybe we should build the technology to make it better,
Mhm.
or the care delivery system. And so I think that's what we have to think about, is on a consistent basis,
Mhm.
how do we continually evaluate the new options that are available without going crazy? And then say, these things are okay, these things need a little tweak, and this thing needs an overhaul. And that has to be a constant way of thinking. That's what we teach in the Mass General Hospital course at Harvard. But it's also how I approach the idea of innovation, which is innovation will make clinical care better when you have created a solution for a specific problem, not when you came up with a great idea and tried to see if it fits somewhere. And I think that's where things are changing now. In the beginning, innovation was all these people came up with great ideas and we tried to see if it would work. And we ended up doing
Yeah.
pilots, but
How to
nothing ever
apply.
scaled, right? Like
Yeah.
you just keep doing pilots and nothing scales.
Yeah.
But now we're really designing a way, hey, you have a problem, the specific problem. We will help you solve for it. We will iterate on it. And now we're really seeing innovation make clinical care.
Yeah. And that's why it really matters, because it can be translated.
Mm-hmm.
So telemedicine, let's talk about telemedicine. And telemedicine existed decades before COVID-19, but the pandemic accelerated the adoption dramatically. You
Yeah.
co-founded several telecardiology programs for underserved communities. Cardiology is a very specialized practice. So what are the challenges that you face implementing such programs?
Yeah. So the first thing when I started doing telemedicine, I realized is I had no hands on the patient. And for a cardiologist, that is terrifying to not have
Yeah.
ears on your patients, to not have hands. And so I started working actually with the Echo Health company now, that at the time was called Echo Devices. And it was one of the first, along with Littman, kind of digital stethoscopes. Because I realized we need to be able to capture the heart sounds wherever you
Mhm.
are, and then be able to sense continuity, right? So here's what the heart sounds sound like. This is how they change. And in fact, now if you think about it, if you put a stethoscope on somebody and I put a stethoscope on somebody, how do we even know we're hearing the same thing?
Mhm.
I will write down what I hear. I hear 2 out of 6. Remember, I will define it. And then you have to understand what I think I said and interpret it if it doesn't make any sense, actually. It no longer makes sense, because now I can just record that heart sound. And then not only can I record it, if I do a heart sound now and I do it again in a year, I can analyze those
Mhm.
heart sounds. And I can tell you whether there's been change, whether there's been progression of valve disease, what is different. And so things like the digital stethoscope, things like a handheld ultrasound to be able to follow somebody into the community and quickly get some pictures that you need, right? Rather than the big machine that you have to push in. The ability to share images from one institution to another. Now we talk about sending pictures like it's no big deal.
Mhm.
It wasn't always that way. It's actually very hard. You had to burn it onto a CD or a videotape and carry the videotapes upside. So all these things, the world has advanced,
Mhm.
and therefore we're bringing some of these advances to medicine. But when you say telemedicine, what are you missing? You're missing everything. So you really do need to build an entire system around it.
Mhm.
Telemedicine can't exist by itself. It is one tool in a whole toolbox of caring for people. And there are times where just seeing somebody in their own element at home is the most appropriate thing.
And this ties to the limits of the telemedicine, that is not just as a standalone tool, it's part of the whole system.
To build a system around it. Yeah.
And where does in-person care remain irreplaceable in terms of telemedicine?
Oh, always there. Hybrid care is essential. And nobody should get entirely 100% telemedicine care. I think there is great value to the laying on of hands. There's great value to learning from somebody in person. There are things on the physical exam that we can capture that imaging can't capture. There are things I can tell you earlier by meeting someone, looking at them, and examining their
Mhm.
body that you may not find unless you do some very advanced, very expensive imaging. And so I don't think we're ever going to get rid of the need for doctors' expertise or ability to diagnose both physical and mental health based on the interaction.
One of my passions is digital health, and digital health is transforming how individuals engage with their own health. How do you define digital health to people who don't know about digital health and
Yeah.
maybe
We
they're
used to
using the
spend,
digital health? Yeah.
you're right. We used to spend a lot of time talking about like what is digital health and how do we define it. I no longer do that. And the reason, I'm glad you asked this question, the reason I no longer do it is not separate from health. There is no place in the world where you say, oh, well, how's your bank account? And then how's your digital bank account? I don't say that, right? That's not something
Yeah.
we do, right? How is your shopping in the store and how is your digital shopping going? It's all right. Sometimes you're ordering something online Other times you're in a store. Sometimes you're at a bank, but more often than not, actually, you're not. You're, on an online kind of portal. True for almost everything. And so there is not a role anymore to differentiate digital health from health. When you care for patients, if it is important to follow them in the community for certain numbers, labs, experiences, then you should follow them to the community, because we now have the technology, previously known as digital health, to be able to follow you into your community. And so I think it is a continuum of where you should be getting your healthcare, and digital health now is really the answer to it's what all of healthcare should be. And in a way, what digital health now means is not everything happens in the big hospital in the city. That's not where healthcare happens. Healthcare happens with you wherever you are. So if you're in your home and you're in your town, that's where it should happen.
Right. So what are the benefits and challenges of digital health tools?
Let's look at you and I. We have different blood pressures. We probably don't have the same blood pressure. And my normal is probably not your normal. How do you know that? Digital health tools, right? I can measure blood pressure continuously for me, for you, heart rate, other things at home. And I can know my own baseline. And then I can know when I'm off from my own baseline. Continuous care is not possible unless you use tools to monitor patients in the communities where they live, what we're going to refer to as digital health for the sake of this question. So continuous care is better than episodic care. Seeing you once a year for something, I rarely am going to be able to manage it. I can't manage something I only measure once a year. I can only manage the things I measure. And if I measure continuously, I can manage better. And so that is digital health. And so that's how it kind of makes it better. What are the risks? The risks are making assumptions based on only digital data and not actually taking the whole person into account. So we want to make sure we understand where you're from. How do you get your medicines from the pharmacy? What are the other things that are happening? And then there's the human connection, right, between you and somebody. And it doesn't have to be every time, but we want to make sure that we have that relationship when we need something. If all you have is digital health, then where's the relationship? Where do you go when you're scared? Where do you go when you're worried? Where do you go when you have side effects? You need a place to go. You need an anchor. And that is the role of the clinician, of the doctor, of the nurse, of the caregiver.
Hey, and patients are now bombarded with digital health tools, same as apps and platforms. And what concerns you the most about the broad and unfiltered access to those tools?
I'm not concerned unless we don't teach our patients to be careful. I want patients to know that what they're using is private and they're not putting personal information to something that's going to be sold to someone or help target them or anything else, right? So privacy. I want people to understand that just because some tool told you something doesn't mean it's exactly right for you. You got to check it. You got to make sure, you got to check in with a doctor. You got to have a system. You got to know the system you trust. And so I don't worry at all about all the options available to patients, largely because we can't take care of patients by saying only I can take care of you. It's not the right way. We need to tell patients, hey, you should have agency. You should feel empowered. You should be measuring things yourself. You should know when you don't feel right. You should be able to tell me about that. To do that, we need to teach them. And I think there is a large movement that's now happening where we used to say, oh, I wish the patient wouldn't look that up. And now we realize, nope, the patient's going to measure that. They're going to look it up, because any one of us would do that. Why wouldn't we advocate for ourselves? So that's a good thing. But now we need some guardrails. Okay, if you're advocating for yourself, make sure that you're not falling for something that's an advertisement. Make sure that you're not developing health-related anxiety because you keep looking these things up without checking it with somebody, right? And so now we need to do the education, and we need to even put the education where people are. If they're on social media getting health information, then there should be trustworthy medical information on social media. If they are on a large language model trying to figure out and ask questions, then the guidelines from the societies should be in that large language model. So at least they're getting the right information. And so I think that's kind of that next step.
Something very interesting that you say is that with digital health, you are able to monitor real time the health status of the patient compared to just having once in a year. And sometimes, very often, people complain, and we also complain that when we go to the doctor, what was affecting us is no longer affected. Right. And then, particularly for cardiologists, like, oh, I was feeling these things in my heart, in my chest, and now it's no longer anymore there. And then you start to feel that you're wasting your time, the doctor's time, the system's time.
That's right. That's right. Absolutely. And that's what is better with continuous care.
Yeah,
Then we know on this day I felt this thing. Let me look it up and find out what was happening. Right.
yeah.
Or at the moment you feel it, why wait 2 weeks to tell a doctor?
Hmm.
The moment you feel it, why don't you look at your own numbers and then maybe trigger the telemedicine doctor associated with that wearable or whatever it might be to say, hey, I'm noticing a difference. I see some numbers that are different here. Do you also see those? Right. And so
Hmm.
that's where the telemedicine platform now meets digital health. Don't just give someone an answer, hey, you're out of range. Give them something to do with it. Give them actionable knowledge. You're
Hmm.
out of range. Here's what some reasons it could be. Or, hey, you're really out of range. Here's a link to a telemedicine appointment. Let's talk about it. And then you can go to your regular doctor or go do whatever, right? But let's address it right away. I think that's the excitement of wearables and telemedicine coming together.
In terms of regulation, because those tools are being developed very quickly, but very often the regulation is just chasing the development of those tools. So how fast these regulations is evolving in
Yeah,
relation?
I think regulation is evolving much faster than it ever had been before.
Great.
Because we have to. So the thing about regulation is patients are going to go get information wherever they can because they can now. So
Hmm.
we need to create an infrastructure for how are they going to get safe medical information. And that infrastructure needs to have guardrails, right? Safe information. So to regulate sounds like, how do you hold back digital technologies from succeeding? Well, let me tell you, if you don't produce the medical digital technologies, they will use non-medical digital technology and pretend it is medical. And so,
Hmm.
how do you fix that? And the way you fix that is by having an infrastructure that you build to say, you don't have to go to these non medical places because we, the medical community, can also feel accessible. We can also give you information that doesn't sound too scientific, that makes sense to you, that is in a language you understand. And so that's what we're really racing to do is we're not racing to regulate. We are
Hmm.
racing to build a safe infrastructure with some clear guardrails so that patients can get the access and information they need because right now they're going outside the medical field for all of it.
Yeah, and they always have done it. So I want to tell you a personal story of mine where last year I started running with my wife. So I've been running with my wife every Saturday. And I started to notice that my heart rate, it was increasing very fast in the first minutes. I was just starting to run and then suddenly it was 150, 160, etc. So then I started to be concerned about that. So one day being a biomedical scientist, I thought, what if I analyze that data? So then I took for my smartwatch, I took the data from the run and I took it to ChatGPT and say, I really need to analyze this data. I need to compare it to these previous runs. Give me the deltas, the variations, give me everything. So it was before midnight. I got the data, I got the plots. Next day, I called the doctor. The doctor is scheduled up an appointment for the following day. I printed, I took my computer to him. I said, doctor, I analyzed, I told the story. I
Yeah.
shared the plot. I put the plot to him. And then he said, yes, let's do all the stress and all those different things to check that everything is normal. And I said, please do. So within a week, I was already being tested. So it was very fast. And, and I was very amazed how this could go. I'm not, I'm not promoting this type of practice, right, to anyone.
But the science is intriguing, right? The fact
Yeah,
that we can analyze something like that, and it's not just healthcare. You could
yeah.
put your financial records in and it could tell you things. Now, the interesting thing is, would you ever put your financial records into one of these models? I don't think you would. I don't think most people would, but
No,
they'll put their health data in.
yeah,
Why is that? Right? This is what we're trying to figure out because
yeah,
we don't consider it necessary. Some people do. Many don't consider it as private relative to the benefit of learning something about yourself because you're worried about your health and you don't know how else to get that information. If you have financial issues, you will find somebody in finance to help you understand it, but you will not upload it for the world to see. But people feel that they can't access healthcare fast
mhm,
enough. There's not somebody there for them to help them understand this. Or maybe they feel it's not a big enough deal to actually bring it to someone because they don't know if something's wrong. So now they're hesitant about it. But whatever it is, you would never put your financial data in a large language model like that, but you would put your healthcare. I hear this again and again. And so there's something about health questions and an inability to get a quick answer that makes people very willing to trust it. And the science is good, but it's not perfect. And that's the problem. When you're looking at the science, if a patient can learn what it says, take it and go to a clinician and say, does this apply directly to me? Here's what I'm learning, but is that in fact me? That's really important. And the number of times that I've done a search or I've put in data and it is 70% right, but 30% not just wrong, the opposite of useful, dangerous. And so you can't trust these systems. They will look like they have it right, but if you push it just a little bit, it will break down. And I recommend anyone who's listening to this to actually take a topic you know really well, whatever you know. If you know how to make the best whatever, right? There's leches. Go and start putting that information in, testing to see whether the ChatGPT or the whatever you want to call your LLM can create what you need. And then push, 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 and you'll find that you'll break it. You'll find at some point it will give you the wrong answer. And once you see that happen, then you realize, oh, this can happen in any field. This can happen in any field.
It can be very biased by your data when you put some information about your career or your CV, etc. ChatGPT is better than your mom in terms of promoting you, and it has to be a balance in things, and you can see the things. Why are you saying this? This is something wrong, it's very important what you said, and to highlight that. Particularly because I was very amazed by this data, is that around 200 million users submit healthcare-related questions to ChatGPT or
Amazing.
every week, and 40 million every day. Wow. But that's one of the challenges, right? But also the advantage is that AI can analyze all this humongous amount of data. I was reading as around 10,000 to 50,000 data points generated per individual daily. So that's a lot.
That's right. That is a ton. It is a ton. And that means people want information, and we're not providing it as a healthcare industry. So they're going where they can go.
Yep. And you mentioned about this, your concern in terms of that we hit that 70% may be right, 30% wrong, etc. That we cannot trust fully the information that comes from that. We need to always bring it to the healthcare professional and be able to sort of discuss it with this. So what concerns you the most about the unsupervised use of this AI? You mentioned about that, but as a regulator, part of the regulator body, is that it is going to be regulated? There will be like a ChatGPT only for, I know they are working at the moment on things, but where to draw the line on this?
It is unreasonable to think that all humans will use only the medically approved mechanisms to get information. It's never been that way. Right? I mean, just think about it. Since the beginning of time, even before we had anything digital, right? The doctor would say, hey, do this, do that. But how many times would you ask the elder in the village what to do? How many times does a pregnant woman ask the other pregnant woman what to do? People seek information from sources that they trust, who don't make them feel judged, and who appear to have some level of experience. And that's true whether you're asking another human or whether you're asking something digital. If it's easily accessible, if it kind of gives you the right answer enough of the time, and if it's not judging you, then you're going to use it. And so there's no way we're going to be able to regulate everything. And that's not the goal. But should patients be instructed on how to interact with this, on when to believe it, on how to make sure that they don't make mistakes based on it? Absolutely. And so education is a large part of the future for us, is how do you educate people? I used to separate health literacy from digital literacy. Oh, are they health literate? Do they understand healthcare? And oh, they digitally literate. And it's all one thing right now. They have to understand how the mechanics of the digital health world work, because that is healthcare now. And we have to start teaching them about the diseases that they have and what they need to know. And so I think education has never been more important as it is today, because people are going to get information no matter what we do from wherever they want. But they can get a lot more information. They can get it explained to them in a very nice way, like you said, right? Even nicer than their mother. But they have to learn to look at it with a critical eye to keep themselves safe. And that's what we need to teach next.
Yeah. And then you made me think that, for example, in Colombia, so there is a lot of traditional knowledge. Like my grandma, she was giving me some herbs to control XYZ condition. And then the doctors, it went from my grandma told me this to Google told me this. and now to AI. Tell me this.
Mm-hmm.
Very interesting shift, isn't it?
And it's a very natural shift. The world is becoming more modern. There's more technology, but it's the same problem. It's exactly what you said. Grandma, Google, and ChatGPT, all the same thing.
And for you guys as a clinician, will be like, oh my goodness, here we go again.
So that's a great point. Right there, I think, is what we have to do differently now. We have spent so much time saying, oh God, my patient is looking up information. And that is the wrong approach that we have. You're right, we have it. We need to start saying, this is great. My patient came looking up information. That's how we need to approach it. This is great. This person is so engaged that they tried to figure out what's happening before they came to me. Positive. So we really need to turn that on its head, and we need to reframe how we think about patient agency. It is not irritating. It is great. It means you have a partner in your patient. It means your patient cares. What would be worse if the patient walks in and says, I don't care, I don't know, doesn't matter, I'll do whatever you want, doc. That's fine. And we used to think that was good, but actually, I'll do whatever you want, take zero responsibility for yourself, right? And what we really want is patients who say, yep, I'll do what I need to do. I want to understand what it is. I'm looking into it myself. And so we really have to reframe that as a positive. When people come in saying, I looked all of this up, the response needs to be, that's amazing. I am so glad you're that engaged. I may not have time to look at what you're giving me right now because our time is limited together. So I'm going to tell you my approach to it. And here's what I think we should do. I love how engaged you are. Here are some sites I want you to go to. What kind of a thing did you get yours from? Did you get it from a TikTok? Did you get it from a podcast? Did you get it from a ChatGPT? Oh, you like podcasts? Okay. Here's 4 podcasts about heart health that you should really listen to that I like. Let me know if any of yours seem excellent and high quality and real, by like real MDs, right? Now all of a sudden they'll be like, oh, high quality, hold on a sec. Doc, wait, tell me yours again, right? Like, but this is the conversation that we need to teach people to have now, is to engage their patients and say, this is great that you looked it up. How did you do it? Where did you go for it? I'm not necessarily going to review everything you gave me because you just gave me a whole stack of papers. But what I will say is, from my perspective, I'm happy you're thinking about it. Here's what I think you need to do. And here's some really reliable sources for you to go to in the future. I hope some of these were reliable. I don't know. I haven't reviewed them. You just gave me all this stuff. But go to these sources. And so that's the kind of conversation I want my fellows to be having, right, as I'm training.
Yeah. And Wearables is a key part of this in terms of monitor, because they will provide all this real-time monitoring. It became from these shiny gadgets to medical tools now. It can read the heart rate, but also oxygen, effort, the hormones. I just read recently that they launched a wearables for hormones. So what excites you the most about this shift in wearables?
I think we can only get so far with remote patient monitoring. We can only prescribe so much to go to the community. At some point, people need to measure themselves. And so I love that the wearables are really engaging patients. I love that they're progressively going for FDA approval or CE mark or other ways to be able to say, yeah, we meet a need, we meet a technology need, we've done some trials. But even as they're on their way to FDA, what I really love is the fact that they help patients believe in themselves. That wearables both give us data on a continuous basis, like we talked about before, know your own baseline and know when you're out of range. Now, the accuracy of the baseline is really important for diagnosis, right? And so that's where we get the FDA approval or the CE mark. We want a kind of technical approval for that is correct. You've shown that those numbers are correct. But even without that, for wearables, just knowing this is where I am and here is how I am off, and proving the science behind that, like when you're off, you are in fact off that baseline, that's extraordinarily important. And it tells patients when they don't feel well, instead of saying, oh, I'm just exhausted, it's a Thursday, right? No, I'm exhausted and my numbers are off too. Something's going on. What could that be, Dr. Carlos, right? And so I think that's kind of what we're moving towards with wearables. The only way we'll ever get population health to work, especially not in non-single payer systems, the only way we'll ever get population health to work is if we allow people to wear wearables of different shapes and sizes and just start to engage with their own health.
You were mentioning before that the way innovation was working before was that people would just come with these ideas and these gadgets and try to apply them into the system. And then you mentioned that it's important that it has to be a focus on the problem rather than focus on the solution. So last year I did a course of innovation in healthcare. here in Perth. It's called Perth Biodesign, which I think follows the Stanford Biodesign process.
Mm-hmm. Mm-hmm.
And then I was immersed in ICU here in one of the hospitals. And I was amazed by the number of softwares that the clinician had to deal with. It was like a four software, one software for taking the pic for the imaging, another software for to collect the data, another software to do this.
Yeah.
And I was also amazed by how clinicians are trained, because clinicians, they don't see problems.
Yeah.
They just be solution driven. Their goal is to save their lives, and their commitment is just amazing to the patient well-being.
Yeah.
Then they go and I saw how it has to go all the way to get to the point they will do it, because it's how they were trained on, etc. So we started asking, do you have any problems? No, we don't have any problems. And and then you can see some of the problems, and because they don't see problems, and that's great, because there is a life on their hands. So I'm just thinking that innovation in healthcare is easy to talk about, but it's hard to implement, because you have to deal with all these walls and mega walls of resistance to change.
Mm-hmm.
So what's your position in terms of that resistance of the health professionals towards innovation?
So the first TEDx I gave, I talked about this phrase that I use, which desperation is the mother of adoption.
Mm-hmm.
It is the best force for change. When you are desperate for something, when your need for something overpowers your ego, your wallet, your politics, and you just need it. I think we are getting to that point in healthcare in a few different ways. So one is there's so much information that we need AI to help us process the information to give the right care to the right patient. The human brain can't comprehend everything that it needs to know.
We can, yeah.
So we need that. The second is there are hundreds of millions of people all over the world who have no access to healthcare because there are not enough providers. There's not enough doctors or nurses to be able to do it. Mm-hmm. So we need to provide them care at a distance, telemedicine. We need to upskill community health workers. We need to think again about who is a healthcare provider. And actually, the healthcare provider is anybody who wants to provide care that is close to the patient.
Mm-hmm.
That's a healthcare provider. And it turns out that we can make those people pretty smart in terms of helping to diagnose this person is sick or not sick. Not the intricacies of this is exactly the drug I would use at this dose. We're not asking for that. Just if I live in a village, can somebody in the village who is a caregiver, doesn't matter what their title is,
mm-hmm.
be educated and upskilled to know heart disease, probably dangerous. Maybe heart disease, maybe not, but whatever it is seems stable. Using the digital health, using the technologies, using the AI. Now, how do you get those technologies to those places? That's always a really big question. You make them cheaper. So when I was in India, I was amazed at how many companies were doing so many different digital health things and at such a reduced cost than we see in the rest of the world, right? They were really just innovating on the fly there in the practice, making things happen. And it did not cost the hundreds of thousands of dollars of marketing budget for your new wearable and so it's really important to recognize that this can be done in an inexpensive way. The second is, what are you doing? Oh, I have AI for a brand new fancy MRI. Great. I want you to keep developing it. But where's the AI on the EKG? Because the ECG is available to everyone, everywhere. It is inexpensive. It's easy for people to understand, and they're used to it already. And so now we're seeing some lovely AI off of ECG that says whether you're not having a heart attack or not, but even you have heart failure, whether your pumping of your heart is low, whether you have a rare disease, all these different things that we're learning. And so I think that's kind of the future that we're headed for, which is there is not an impediment to change or resistance to change as much as there is a desperation to actually provide healthcare. And that is now finally outweighing any sense of inertia, if you really look closely.
So one of the previous guests, Dr. Amy, she mentioned that the health systems were not built for women in mind. And in that case, as well as for other underserved population as well. So how innovation can change this, particularly for women's health?
Yeah. So I think moving care into the communities where people live is very helpful for women in general. I'm making a generalization, but unfortunately, I think it is
Mhm,
still true that a lot of the home and family life throughout the world is run by women. Not everywhere, not all the time, but unfortunately, that is still the case. I think also it's important to recognize that women right now are one of the fastest growing contingents of kind of healthcare consumers who are doing so intelligently and with an active lens. And so if you get the woman to start measuring herself, getting healthy, etc., seeing clinicians, then we know that that woman will take her friends with her, will take her family with her, whether it's
mhm,
older, younger, her age, right? Those women are the pillars of the community. And if they choose a healthy lifestyle, if they choose a specific health system, if they choose a wearable, people around them will likely follow. And so I think we're already redesigning it just because we're pushing care into the community and we are empowering patients. And by pushing care to the community, you're pushing care to be central around women. And by encouraging measurement, you are encouraging female participation. Now, what about things like trials? I think when we work at journals, for example, and we accept research papers, no journal should accept a research paper unless it is at least 50%, if not greater, women. All
mhm,
research must be done in women. There's no reason, unless it's something that's just a male only problem, but
mhm,
shy of that. And so we have to be really careful. Like, I won't accept research that did not try and be diverse. There are
mhm,
diverse populations everywhere. Find them, go through the extra effort to make sure that this is fair research applicable to anybody, not just one subset of the human population. And so I think those kind of changes are next, the data that
mhm,
we're collecting, the trials that we do, the participation of women. But if you just talk about healthcare, preventative health, population health, by moving care into the community, number one, and by encouraging self monitoring, number two, those things are likely to make women more prominent consumers and eventually directors of what should
mhm.
happen in medicine.
So today we see isolated clouds of innovation in prevention, diagnosis, and treatment. So in each one of those areas, you see that there is a lot of innovation happening. New drugs, new medical devices, and diagnostic biomarkers, discovery of biomarkers, etc. So what are the main barriers? We can talk about technology, data privacy, etc., preventing an integration of those and end-to-end patient care.
Yeah. End to end patient care is hard, even if we're not talking about digital, right? There are so many different sites,
Mhm,
situations, cases, mechanisms, presentations. And so, what we really need in order to do end to end care is we need flexibility. We need to know that people can go from being inpatient to being outpatient to being home and back in
mhm,
flexibly. We need to have systems that follow you wherever you go. So, for example, if we go back to thinking about the wearables, what I really want to see is not just where were you last week, Dr. Carlos, where are you today? I want to say, at age 23, what did things look like? And what did that progress like by 27?
mhm.
And by 32, what am I seeing? And now all of a sudden, I'm predicting perimenopausal changes for half the world because I've been following them that long. And so I think what's really important is that as we enter this patient engagement, patient agency realm of healthcare, which is long overdue, your health should have been your own a long time ago, but we held the capital, we held the knowledge. The knowledge is no longer held by us as doctors. The
Uh-huh.
knowledge is free, right?
Yeah.
And so now, with the knowledge being free, the patients can take that knowledge and they can learn. And so I think it's really important for us to now embrace that
Uh-huh.
and say, yeah, that's what we want. We want those patients to learn. And I think that's incredibly, incredibly important for us.
What needs to happen to make this a reality in terms of government, for example, policies to facilitate this integration of information
You know,
coming
we
from.
have some of this happening in the United States right now. There's a couple programs. The Access program is a program that's trying to set up remote monitoring payment system, especially for small hospitals, rural areas that aren't able to set up their own system. Can they partner with a company who can do this for them and be able to provide better care for their patients? And then the company also gets paid, and so everybody's happy. There's also this new program called the Advocate program coming out of
Mhm,
the US. And this program is kind of millions, tens of millions of dollars dedicated to groups who are willing to study, can we have AI agents that successfully help us manage patients at scale? And they're specifically thinking about cardiometabolic, so hypertension,
mhm,
heart failure. Heart failure, actually, for Advocate is the first thing. Hypertension for the Access program is the first
mhm,
thing. And so we're really addressing these concepts. There's a lot of education that needs to be done. So we, are creating the AI-enabled clinician at the American College of Cardiology. It's kind of my baby, which is like, how do you teach all these people in medicine how to not be scared of AI, right? How to understand where it fits, how to think about where it should go, whether or not you want to use it, right? Whether or not you want to deploy it, what do you want to deploy it for? AI enabled, not the one writing the programs necessarily, although vibe coding makes this a lot easier in prompt generation, but not necessarily the one writing those, but the one who understands how to assess it in practice. Where does it fit? And so I think that AI enabled clinician is just a really important part of where we're headed.
Now we're going to talk about the low resource settings. You have developed and deployed telemedicine and digital health tools in underserved and low resource communities. What are the challenges in deploying such technology in those settings?
Yeah. So when we first did this work out of MGH, it was certain that some things like access to be able to do the video, right, was harder than telephone. Now, whether that's in terms of how much data one's using, what access you have, but there was definitely telephone was better than the video. Actually, not, I shouldn't say better, was more used than video. The price point for some of these technologies, the remote monitoring and the wearables, is not reasonable for underserved populations. So I think we need to subsidize. There needs to be some subsidy of this. What I love to see is, clinical trials that are ongoing need to not just be in well-off areas. Clinical trials need to include people who suffer the most, especially from cardiometabolic disease, from cardiac disease, right? And those populations that are at greatest risk are the ones where we say, oh, well, it's hard to get wearables into this market. It's a consumer market, things cost money. But wouldn't it be great if we could help enroll some of the patients in these areas into trials? Because then we would actually learn how to help treat them. What is the best care for them? And if you're running those trials, and now you also say, by the way, if you're in this trial, you get a wearable. Now you're creating a whole different mechanism of people who ordinarily were at the greatest risk with zero access, being not only enrolled in a trial so that more information is known about them so we can create better drugs and devices for them, but we also at the same time are giving them access to wearables and encouraging them to use it. Why does that work? Because wearables are really good at engagement. They are. That's what they do, right? Healthcare is not great at engagement. Wearables great at engagement. And so now with a wearable, you have a patient who's in a clinical trial who's engaged. That's all we want, because we want them to stay in the clinical trial. And so that's just one model that I'm kind of showing you of what could the future look like. How do we create a model that specifically fights the inequity, this equity issue, whatever you want to call it, digital divide, right? The biases, it's not just going to go away by itself. We need to actually actively design mechanisms to not just make things equal, but to actually lift those up who have not been involved before. And so the example I give is just one that I've been talking about with people this week, so it's on the top of my head. But it gives you more patients enrolled in trials, right? It gives you patients enrolled in trials that are now getting care because they're in the trial. No access problem anymore, and data to help inform those communities' healthcare better. And if you add on access to the kind of digital technologies you may not have because you're participating, which will also increase your engagement and keep you in the trial, it's a win for everyone. So I want people to think of those models. I'll give you a different example. There's AI in almost all the imaging we do. So if reading CAT scans or ultrasounds at the hospital, we're reading them in the order that they were done. The first one came in, Dr. Carlos read it. The second one came in, Dr. Ami read it, right? We do this. But now we have AI doing a preliminary read, right? There's already a little bit of an auto read when we get to writing our own report. What if that preliminary read could say, hey, the fifth CAT scan that came in today, very dangerous. Something's going on. But I'm on number 3. So what happens? They switch 4 and 5. They give me the next most dangerous thing. Is the AI taking my job and doing my work and making all the diagnoses and talking to the patient and calling the floor and getting them to search? No. But is the AI very quickly able to say, 20 scans came in, these 7 are dangerous, read them first, Dr. Remy? Absolutely. So again, that is a way to provide better care. That is a way to avoid digital divide. That is a way to bring equity to a process where it doesn't matter who you are. If you are the next sickest patient, I will address you next. And so those are the kind of things we need to see. That's how we're going to close the equity gap, is by intentional movements to close the gap. It doesn't happen just because we try and be inclusive. That hasn't worked.
And
No.
that's beautiful. Be able to sort of have a patient, no matter what the background is, at the
Yep.
center of the care is just fantastic.
That's what we need.
What can high income systems learn from low resource settings?
Yeah. First of all, that it can be done cheaper. I mean, it can, right? It can absolutely be done in a less expensive way. There is
Mhm,
no doubt, right? The second is, there's this phrase, right? That the perfect is the enemy of good, something
mhm,
like that, right? And I think it's really true in medicine. We say, well, the gold standard is to see a physician. Well,
mhm,
first of all, it's actually not the gold standard, because a physician's brain is not as strong as an AI brain. So maybe the gold standard is to see a physician who's using AI. Let's just start with that.
mhm,
But the gold standard is getting a full test that does 134 images. Well, do you know how much time and money that takes? Do you know how hard that is to do? But what if, instead of an ultrasound with 134 images at the hospital, I could take a handheld ultrasound, get 5 images, use a little bit of AI to make sure that I've gotten it correctly and to give me a prelim diagnosis. And now I know if that patient's relatively safe or if they're sick. Somebody would say, Dr. Bhatt, that's not right. That person needs better care. That person needs a full echocardiogram. That person needs a thorough ultrasound. And my answer to you is, that patient was never going to get any ultrasound.
mhm,
So the fact that I brought 5 images and figured out if they're sick, that's better. And so what we can learn at the higher kind of fiscal realm institutions from the developing countries, or those who are, in the more struggling environment, is, one, it can be done less expensive, absolutely. And number two, don't set some unreasonable goal as the gold standard when you have the potential to help so many more people. It has to be a reasonable goal, right? You don't want to offer bad care. But if you offer care that can improve outcomes, then it kind of doesn't matter how exquisite that care is, as
mhm,
long as it's patient centric and it gets people to better outcomes. And that's what we have to remain focused on as our goal. You see a lot of AI at these large institutions,
mhm,
and they say, oh, well, AI was aimed at efficiency. The AI was aimed at the fiscal bottom line.
mhm.
And my answer all the time now is, I only want AI for outcomes. If it gets you your efficiency and bottom line, great. But efficiency and bottom line alone, absolutely not enough for implementation. I want to see it affect outcomes. It's time to start pushing. Now you can say, oh, of course, we saved money, so we could
Mhm.
spend that money on outcomes. Great. But then I want you to show me that the money you saved got delivered to an outcome. And it's now the opposite, right? How many years have we spent? And I say we as if I wasn't actually an administrator in a hospital. So I have been on both sides, right? But as a clinician, how long do you spend saying, here's why I need this? Here's the outcome that will improve, right? And as an administrator, you're really trying to figure out, how do I cut those costs to be able to still get the care? And what we need to see is all of that working together to say, I will implement programs that will improve outcomes. I would like to implement a program that improves outcomes and creates some efficiency or some fiscal improvement, but I won't always have that. But I should never implement something that will just do a fiscal outcome or an efficiency, and nothing about that improvement will ever feed towards better outcomes. Somebody has to demand that whatever efficiency and fiscal I have still gets to outcomes eventually. The end story is, large, well off hospitals can learn from public or developing hospitals that things can be done less expensive, that the gold standard really needs to be reassessed, and that outcomes always come first.
So, which gaps in healthcare are yet to be explored? And I just want to join this with, what are the most common pitfalls that entrepreneurs face when building digital health and AI-driven solutions?
Most common pitfall, there are two. All right.
Mhm,
One is thinking that you need to expand and do lots of things. You don't.
mhm,
You need to do one thing, and you need to do it better than anybody else could possibly do it. That is your only goal in life as an entrepreneur. I do this thing, and there is nobody who does it better, because that makes your company and your product inevitable. It's going to be the thing. You just know it's going to be the thing because nobody else does it, and it's needed. That's the number two. Don't develop something that you're not positive people need. Just don't do it. Find that unmet need. Find what I started with. Find the desperation. and solve for it. If you find the desperation, you create technology to solve for it, and you don't stray from that goal, you stay focused, you're going to have a company. You're going to have a company that flies. You're going to have a company that's bought out. You're going to have a company that makes you money. And most importantly, you're going to have a company that makes a difference in the world.
So, what advice would you give to young scientists or clinicians who want to work at the intersection of medicine and innovation?
You can do it now. You don't need training. There's nothing that needs to be done. Think about what needs to be better and start looking around all over the world outside the discipline of medicine to start finding solutions and bring them back and consider it and think about it and apply it and use it in your own life. The way I started is I used telemedicine in my own practice and nowhere else, just with my patients. And then I brought some stethoscopes to clinic and I had my students use these stethoscopes on my patients. I made my own little world a test kitchen for all these things. And I took everyone along with me. My patients all knew, hey, she's going to have a new toy in the office today. And the fellows all knew, what thing are we going to try today with Dr. Bhatt? And how are we going to think about things differently? And so I created my own world of experimentation. And so what I would tell people who want to be on that verge of medicine and innovation, just do it. Do it around yourself. Do it in your own life. Do it with your own patients, and start trying. Now, don't do scary things, right? So don't do it in place of something. I never used a digital stethoscope and said, and I won't do this the usual way. I did it on top of, hey, I kind of want to test this and see how it compares. Do you mind if we just try this? And it was never something that could hurt a patient. It was only something that could provide some additional information. And it was never something that risked their privacy. So you have to be careful what you're doing. But again, start innovating now.
Great. And this is the last question. This is about legacy. When people look back at your work in 20 years, what impact would you hope it had on humanity?
Wow, that's a good question, Carlos. I'll give you 2 answers. No, I'll give you 3. Oh gosh, I have a long list of answers, but okay. I'll start with the first one, which is I think I would love if people would say, or if I could know that I helped bring high quality, rigorous care all the way into the community where the patient was. That I was part of that engine that figured out how you bring really good healthcare directly to the patient. So I think that's probably like my North Star, right? High quality care right with the patient. If you thought about it differently, I would say that I maybe helped redefine 2 things. One is we often call, leaving the hospital, going home, that last mile of healthcare. And it's kind of the same idea, but I hope people would say, yes, she redefined it as the first mile of healthcare starts with the patient in the home. And we all think about it that way now because of the way that, Dr. Bhatt expressed it. And maybe the third thing is I do want, and this is not like someday on my tombstone, like I want this in the next few years. I want people to really say it's not consumerism, it's patient agency. People wanting to know about their own bodies, people wanting to know about their own health. That's great. And I want all clinicians in all of healthcare to feel that. And right now, that's not where we've come from. We've come from a place of privilege where we carry the knowledge, and where if we have not given the knowledge is not there. And now the knowledge is all around us, and our field is struggling with that. And I want to be one of the ones that makes people feel okay with it and feel happy and understand it's not consumerism, it's patient agency. We should be grateful when our patients want to figure this out. And I really want that kind of rebirth of how we think about a patient and their health to be something that I leave. And I'd say most importantly, I want my kids to be happy I was their mom. I think, that before anything else, I think like that's the one, right? I want my kids to be really happy. Like, yeah, that was my mom, or that is my mom. I don't want to go anywhere yet. So, yeah.
Thank you, Dr. Amin, for all this fantastic conversation. I could just continue on discussing about different things. I have other questions there, but I'm very aware of your time, limited time. And thank you so much for being part of this podcast and sharing all your experience, your vision. And I look forward for people to comment and learn from what you are saying. And I'm sure that it will resonate with many people. So thank you, Dr. Amy, for being part of this podcast.
Well, thank you so much for having me. And for anybody who wants to look for me otherwise, I'm on LinkedIn a lot, as Dr. Carlos knows. And I'm also available at dramipat.com for kind of insights, thoughts, and getting your feedback.